So good afternoon. I hope everybody is safe. It's been a very stressful period, both in terms of being at home and also watching the horrible virus going around. So I think it's now been from the government side, we've got an approval to start our vision centers. So I think before we get into opening up the vision centers, I thought it would be good to have a little bit of a knowledge as to why we'll have to be extremely cautious in opening our vision centers. So just to, I'm sure all of you know, or most of you would know, but there would be a few who would benefit out of this particular slide. So I just wanted to emphasize. I'm not sure how many of you know why it's called COVID. CO stands for corona, VI stands for virus, and D for disease. Since it started in the December of 2019, we call it COVID-19. It has not been a very dangerous virus because there have been other viruses causing flu-like symptoms. So it hasn't been very dangerous, except for a few in the past. So not to be too depressed or worried or overstressed. But what we request everybody to do is to be cautious. So as far as the symptoms of COVID is concerned, this is more at an optometrist level. We need to know that fever, cough, shortness of breath, eventually leading to pneumonia is what is commonly noticed in COVID-19. And there's only one way of confirming, that is to do a RT-PCR, which is not a very easy test to be performed across the country. And it's not available, this facility is not available, and it's not cheap as well. It is an expensive test, and I don't think most people in the country would be able to afford it. And what is most important is that the area that we are working on, that's the older people, the diabetics, cardiac patients, they're more at the risk of this particular condition. And this is exactly the type of patients we'll be coming across in ophthalmology. So that's one area that we need to be very careful about. So another area that is of concern is we are in close proximity with the patients, especially when we are trying to examine the patients. And unfortunately, our neighbor is the one which harbors the virus, which is the nasal mucosa, the oral mucosa. All of these have the virus. So that's the reason why we'll have to be extremely cautious. And the disease actually is transmitted only through the respiratory droplets, which means even talking could produce droplets which can infect a person sitting either by the side or across the particular patient. And touching surfaces which have been contaminated with the virus also could cause this particular condition. So the only simplest advice would be never to touch your eyes, nose, mouth, anywhere when you're outside of the house. And the very good news here is simple disinfectants can kill it. To be very precise, just a good hand wash with a soap would kill the virus. That's the good news. So it's very, very easy to control this. But let me put in a word of caution. No vision center should be opened in a containment zone. So please remember, you'll have to be constantly on the lookout and see for the containment zones. And if ever your vision center is positioned in a containment zone, please do not open it. And if ever it falls eventually, please close it and do not provide any services. Now I'm going to present to you a set of guidelines, which is a collaboration of what we practice, and it goes by the government guidelines as well. So the goal here is to provide a protected atmosphere for both the staff, vision center staff, and the patients who are seeking service from the vision center. But remember, priority is always given to the emergencies and the common eye problems. So by giving priority to the emergencies, we are actually bringing down the eventuality, which is eventually the blindness. You're bringing down that portion and taking care of the common eye problems by performing the appropriate tests, which would in fact reduce the number of referrals to the base hospital. And also remember, you perform the appropriate tests and also avoid unnecessary reviews even in the vision center. Sometimes you keep asking the patients to come the day after and the day after just to look at the progress. At this point of time, the emphasis has to be given to the treatment, and please avoid unnecessary reviews. Now, all these have to be done without compromising the quality of care that you're providing to the patient. And you should also ensure that you're complying with the government regulations. So we have to be on the lookout for all the regulations, because the regulations are changing as the disease pattern is changing, and the guidelines which are coming out also are taking different versions. So we have to be constantly on the lookout. Now, as far as the vision centers are concerned, I'm just taking the example of the Aravind Vision Centers, where we have the area available from a minimum of 300 square feet to a maximum of 600 square feet. Now, what we first decided to do was create a waiting area outside of the vision center. Now, we are not talking about a luxurious waiting area. Sometimes you might have just a tree to give some shade. That's probably enough. All you need to do is rearrange the seats in such a way just that it is 3 feet apart. So each patient is about 3 feet away from each other. So a simple one, this is a very rusted bench. You could just use that and space them out. That's all is necessary. And remember, we need to have just 3 or 4 patients inside the vision center at any point of time. So in fact, you would have 6 people inside the vision center. That is 3 to 4 patients with the 2 technicians. And please remember to schedule the patients. When I say schedule, it might sound a little overwhelming. It is very simple. All you need to do is just space them out. Don't allow them to crowd either outside of the vision center or inside of the vision center. So what you can do is you can adapt very simple techniques like providing tokens to the patients and numbering them and telling them that it would take them so much time. So you can come back at 2 o'clock, whatever. You can schedule them appropriately, whatever is feasible for your particular vision center. And do not allow attenders inside the vision center except for extremely vulnerable patients, especially when you're examining a child or a very elderly patient who needs assistance. And one word of caution when I say this, awareness posters on hand washing, social distancing, and use of face masks. These posters can be made, but remember you have to clean these posters as well. These could also harbor the viruses. So you can make it such that it's outside where they're waiting. And please provide masks for patients if they do not have any. Most of them would come with just a green cloth. It's actually not advisable. You should have a 3-layered mask for the patients. If it's not available with the patient, try to sell them to the patients. It's both for the benefit of the patient as well as for the examiner and the co-patients who are waiting. Hand washing is mandatory. You'll have to ensure that the patients wash their hands. Use the antiseptic solution before entering the vision center. Temperature has to be checked. Now the question would be, what if the temperature is a little high? Now you'll have to understand that they're all under the hot sun, so there might be a little rise of temperature. So you please ask the patients to wait and do a repeat check after a little while. And if it still persists to be high, you will have to defer the examination of that patient. And probably we'll talk about it a little later about how to handle if there is an increase in temperature. COVID consent is a mandate before you even register. There are many reasons for having this COVID consent. One, this is the only point of contact for any of the government officials or any authorities which needs to track the patient down. So if the patient has come to your vision center, please obtain the consent, which will have a lot of details. I've just put it a little more elaborately so that each one of us concentrates on all of these, because it's very, very relevant to the vision centers because they are located in the villages. You should find out the place of work of the patient, which involves exposure to a large group, especially in marketplaces. Have they worked in such locations? Any travel history, because most of the villages, they have either national travel or they could be from any districts which could have a hotspot, which could be a containment zone. So it's always best to find out the travel history in detail. A family history of any travel by the family members. It could be an inter-district or interstate in the past 28 days. Any history of symptoms in the past 28 days, like upper respiratory tract infection. It could be just a common cold, or a lower respiratory tract infection, which could be in the form of a cough, which could be permanent, or it could be productive cough, whatever. All of these have to be registered. Any history of fever in the past, or diarrhea. It is also supposed to cause diarrhea. So we should ensure that all of these are recorded in your consent form. Any family member on COVID duty living in the same house. They could be police, it could be an army, it could be a doctor, it could be a nurse, drivers, whatever be it. You should ensure that you record all of these in your consent form. Contact history with a suspected or a diagnosed COVID case in the past 28 days also should be recorded. And we should also look at the fever, cough, expectoration, breathlessness, history, sore throat, nasal block, rhinorrhea. That is, rhinorrhea is just running nose, cough, and GI symptoms like diarrhea. If the patient has had contact with anybody having any of these symptoms, it is important. One, you should ensure that you record whether the patient has any of these, or is the patient having any family member having all these, or is in contact with anybody having all of these. Contact with any symptomatic patients or any visit to the containment zone should also be elicited. No patient is ever going to reveal to you in any way, however you ask. So it's best to put all these questions to the patient so that at some point he would give in and would tell us the truth. Now, the next most important aspect is ensuring staff safety. We've looked a lot about the patient safety part. Now, let's look at what we need to do with our staff. The staff are requested to wear the mask from home. They should wear their personal clothing to work, bring their uniforms. If they are not practicing uniforms, probably they can bring another set of clothes, and they should use that. The uniform should be used in the vision center, and they should change before they go to work, before they go home as well. So they come to work in a particular set of clothes, change to uniform, and before they go back, they'll have to go back to their set of clothes and take that uniform with them, which is properly covered and has to be decontaminated. You can just soak it in hot water, use soap, and wash the clothes. Please remember, minimum number of personal belongings, especially lunch boxes, water bottles only. Because normally we have the tendency of carrying 2 or 3 bags because you see some fresh vegetables on the way back, things to buy, shopping lists, all that should not be entertained. And preferably no watch, jewelry worn on hands. And remember, stainless steel attracts and sustains the virus for 3 days. Okay, so most of our watches are stainless steel, I'm assuming. So we will avoid all jewelry on hands, both men and women. Staff should wash hands before entering the vision center. Use antiseptic on entering the vision center. Check the temperature as they enter the vision center. Ensure the attendance by looking into the web camera. You can either use a register. I think you should go by what your hospital stipulates. but we are following the practice of looking into the web camera, use of safety gears and maintenance of asepsis in the workplace. And remember, this is very, very important. In the enthusiasm and zeal after having stayed for so long at home, even if you're unwell, you do not have to come to the vision center. If there is any trace of illness, whatever I described, this cold, fever, cough, whatever, please bring it to the notice of the authorities, that is your own authorities. Escalate the problem to your chief medical officer or whoever is in charge of your vision centers, and please stay at home. This is mandate. Now, during your work, keep the doors open, especially to avoid touching the doorknobs and handles. One, it provides a lot of ventilation, and the other, it avoids touching the doorknobs and handles. Sanitize the phone, ID cards, all of these. Clean all surfaces. Sodium hypochlorite solution is recommended very heavily to clean chairs, stools, desks. Alcohol swab is used for slit lamp, computers, and keyboard. Please remember, you're all by yourself. In your enthusiasm and zeal, please do not change the fluids that is required to clean. So whatever is being advocated for the specific equipments should be used. And after you've done all these, please wash your hands before you start your work. So wear your PPE. Now the PPE, I put it as a gross terminology. There has been stipulations and mandates which have been changing from day to day. I'll be talking about the few things which we have been following, and I'll share how you need to decontaminate these as well. Physical distancing is very important. What we have not been practicing earlier has to become a mandate within the vision center. Please avoid touching the face and remind the patients also. Hand sanitizing during examination and also in between patient examinations. This is something very, very important which we might not have practiced earlier, but it becomes very relevant today. Now, how do we manage the PPE? Now, there is a controversy about what kind of a mask should be worn. Now, I'll go through what we've been adopting, and then I'll also tell you the merits and demerits. Now, the mask has to be placed carefully. The idea is you cover your mouth, nose, and minimize the gaps between the face and the mask. So if you're going to use, and again, very, very important is, do not touch the mask while in use, because the front surface of that is the outer surface of the mask is something which is contaminated because you're dealing with patients. So do not you touch the outside or the outer surface of the mask. And remove the mask by using the appropriate technique. You might want to drink water, have lunch. Do not touch the front, but remove from behind. This is something that you have to really follow very carefully. And it has been advised very strictly that we should not reuse the 3-ply surgical mask. Do not reuse the 3-ply surgical mask, or do not use the 3-ply surgical mask for more than 8 hours. Remember, these things are very important. So a 3-ply surgical mask has 3 layers. This is supposed to be very protective. As of now, we are in the moderate risk group, especially in the vision centers. We are almost between the low to the moderate risk only. So a 3-ply surgical mask is more than adequate, but it cannot be reused, and you should not use it for more than 8 hours. Obviously, we're not going to be staying in the vision center for more than 8 hours, but remember, it cannot be reused. On the contrary, the respirators, you can reuse it after it has been decontaminated by just hanging on a ventilated indoor area. Don't leave it outside because the crows can take it away. So just leave it in a well-ventilated indoor area for 72 hours, and that can be reused. And respirator again is very tight fitting. That is the advantage against the 3-ply surgical mask. With a 3-ply surgical mask, there is a possibility of creating a space between the face and the mask. But with the respirator, it's very tight and it's really sealed. Having said that, it's very, very difficult to use it. When you remove, you have to hold the respirator by both the sides and the back surface and fold it onto itself. Store the mask after folding it onto itself in a Ziploc bag. It is reused by wearing it back without touching the front surface. So again, it's very, very important that you don't touch the outer surface or the front surface. With the 3-ply mask, it is kind of comfortable, but you can't reuse. But with the respirator, you can reuse it for 72 hours. And then the face shield, we normally advocate a face shield to be worn for patient examination, which can be decontaminated using Lysol. Now, if you look at the patient examination, it's very important that you keep the patient sitting 3 feet away while you're eliciting the history and complaints. Get all the required information about his condition, his or her condition, and instruct the patient about the examination procedure and also what it involves in teleconsultation. Instruct the patient not to talk during the slit lamp examination, and make the patient sit back after the examination and then try to explain about the eye condition before you go in for a teleconsultation. Now, as you're doing patient examination, there are things you need to do upfront. Over here in base hospitals or secondary hospitals, what we have is a triage area where patients with frank conjunctivitis are seen just at the triage area and patients are given the necessary drops and sent away. So the same thing is applicable in a vision center as well. So you have a separate area where when you see a patient with a frank conjunctivitis, you need to use a disposable glove which can be used to examine the patient. Please do not try to evert the lid. Try to use a cotton bud to retract or evert the lid. And after you have examined the patient with conjunctivitis, you just dispose the gloves only after washing the gloves with soap. So remember, it is important that we should not leave the virus on the glove. So you need to wash your hands before you dispose the gloves that you've been wearing to examine a conjunctivitis patient. Avoid measuring the blood pressure because you need to tie the cuff to the patient, or if it is a necessity, then you have to clean it with Lysol after you've used it on the patient. Applanation tonometry again has not been advocated yet because it's again an unnecessary test, but if the patient requires to have the test, you have to do it, and then you can use it and clean the lens before you use it on the next patient. And another word of caution is syringing or Rho plus test should not be done. Instead, you can use a fluorescent dye disappearance test. I don't think it would come to you as an emergency. When patients come to you with watering and discharge, it's almost obvious that the patient is having a lacrimal pathology. If you want to confirm it, just use a fluorescent dye disappearance test. Do not advocate syringing or Rho plus. Again, I'm insisting that we do not do syringing or Rho plus. Now here, if you can watch, the technician is having a face shield and then there is a slit lamp guard. So there are many points of interruption for the virus. And you should actually try not to touch the patient at any point of time unless it's absolutely necessary. Even to examine, you ask the patient to retract the lid, but on slit lamp you can use a bud to retract the lid. Cotton bud is easy to acquire and you can use that to evert the lids. Now again, this is how it is being done. The examination is done and the technician gets all the information, and if you watch very carefully, the technician does not hand over the mic to the patient. The technician is holding the mic because this is another point of contact for the patient. So try to avoid all points of contact from the patient to any of the gadgets in the vision center. Now, during the refraction process, you do the vision screening and refraction, maintaining a distance of about 2 to 3 feet, which is what is mandated for every activity for anybody in this world today. If the patient has 6/6 and N6 unaided with the current spectacles, I think we should avoid doing a retinoscopy or any other tests for any supportive visual aids. I think it's not necessary at this point of time because the patient has got good vision. And please don't encourage patients coming for new glasses, different glasses. I want 3 or 4 glasses. At this point of time, it's not necessary if they are N6 and 6/6. And refraction needs to be done only when it's necessary, only during this particular period. Glasses can be prescribed and dispensed. Actually, we have to give a little attention to this point. We need to give them glasses because a lot of them come to us with broken glasses, or they may come to us suddenly becoming presbyopic. So please understand that glasses dispensing would become an important part of the vision center activity. Again, for dilatation, when it's absolutely necessary, you will have to instill the drops by not touching the patient, by asking the patient to evert, which is normally not very well cooperated. So you can use a bud. Now again, another important aspect which we all have to concentrate, and you should also remember that this is another point of contact. People would like to look at many frames, try to try it on, all those things. So you will have to also respect their, their wants, likes and dislikes, though not very extensively, but we'll have to, once you allow them to touch the samples, wear it, you will have to disinfect them immediately before you're putting back into the cases. So again, as they're sitting and trying it out, they will be sitting down, their seats have to be disinfected, the mirrors have to be disinfected, the furniture there, the table, all those have to be disinfected before you let the next patient to come and do necessary aspects. Now again, look at this very carefully. For the frames, we need to use only hydrogen peroxide or just the liquid soap. But for the lenses, you use alcohol. Please don't spoil the frames by using alcohol. And at this point of time, it's recommended that we use tissue paper instead of using the cloth, because when you have a cloth, there is a tendency to reuse. But when you have a tissue paper to clean, you would eventually dispose it. So that's the only logic here. And at this point of time, it's very important that we ensure that teleconsultation is made a mandate for every patient. And you should also ensure that the information given by the patient before examination has started should be passed on to the doctor by the technician. So whatever information you have gathered, please pass it on to the doctor before you start the teleconsultation. And remember, mic never to be handed by the patient. Mic has to be handled only by the technician. And most important, there'll be a lot of patients with who would require anti-glaucoma drugs, or after cataract surgery, they might require some drugs. Medicines have to be provided to the patients based on the doctor's advice from the base hospital. And again, reference to the base hospital. The whole idea of opening up vision center is we don't want to have footfalls in the base hospital, thereby crowding the base hospital. And also remember, many of our districts, the buses have not started plying. So it is very difficult for the patients to get all the passes and come to the base hospital. So try to avoid all elective referrals, especially cataract surgeries when it's not mature. Again, overemphasis for this fact. Do not refer immature cataracts. Refer mature cataracts at this point of time. When I say mature, it includes 1/60 hand movements, PL plus, all those things. And there are some cases where they've gone in for phacolytic glaucoma, phacomorphic glaucoma. All those become emergencies and they have to be referred to the base hospital. elective surgeries will come over a period of time. I think it's the base hospitals will be battling with the elective surgeries first, and then they can slowly pull in the patients from the vision centers as well. But one thing you need to do is document all the patients who require referral to the base hospital, even if it was an elective case. And you should have all details about these patients so that later on, when things open up and we are free from all these frustrating restrictions, you could probably bring them back into our system. So I just put these services, what becomes essential and what becomes desirable based on the crowd that you have. Early detection, see, essential is detection of eye problems. After all, having a vision center is only to ease the patients and get rid of all the trouble of going through, getting into a bus, traveling. And at this point, with a lot of economic crunches, I think we should make it possible that all vision centers take care of basic eye problems, which could start off with a conjunctivitis, blepharitis, it could be a stye. All of these can be taken care of at the vision center level. Even having a small corneal foreign body which is not deeply embedded, all of these could be taken care of at the vision center level. We should be able to manage any emergencies. Like for example, if you see a corneal tear, you know that for sure it requires a suturing. We should give the first line management, bandage the eye, check the vision, and immediately send the patients to the base hospital. And I think refraction becomes mandatory at this point of time. As the services start with grinding, I think we should also start dispensing the spectacles, because that has become, I don't think people should travel this far just for a pair of glasses. And what would be desirable over a period of time is, you can keep constantly monitoring. You have a lot of diabetic patients, you have a lot of glaucoma patients who would be constantly being monitored or followed up, and you should ensure that you take, you look at their fundus. If it's necessary, if the vision is deteriorating, you have to motivate these patients, counsel them, and probably escalate them to the base hospital if there is a vision drop. And of course, community-based rehabilitation and rehabilitation of the visually impaired will not be possible at the moment, but keep in mind that this could be done if there is not much of a activity in the vision center. But remember, no patient education should happen in terms of having a group gathered in the vision center. We would normally encourage the volunteers to come and have a patient education in the form of group discussions on those things. Please don't do all that at this point of time. No mobilizing crowd in the vision centers. Now, after having listened to all this, what I need to tell you is I have to make a very honest confession that after having followed all these, though we have kept all these stringent aspects, what we found to our surprise was a very unusual pattern. Normally, I'll just take one example. On a normal day, we would have about 30 patients in a vision center at Aravind Eye Care System. Now, if you look at it, the way it is we are almost having half the numbers. And in some places, it's moved up to 3/4 over a period of a week. So it's been just a week, and we've had almost a surge in the numbers, which only means to say that people are waiting to be offered the services. And it is very, very bad on our part. Actually, I should say it's not fair on our part if we don't give this service to these patients. And unfortunately, I have to admit that in the hospitals, base hospitals, we're seeing almost 1/6 or 1/8 in the base hospitals versus what we see, which is, to me, I feel very happy about it, because these are really deserving patients, and they don't have the economics or the means to come to the base hospital. So I think it's very important that whoever is wanting to open up vision centers, or whoever is on the move towards it, please, I think you should, because this is the best way we can serve people, at this hour of need. Thank you very much, and I'm open for all questions at this moment.
So one of the questions is, can we begin comprehensive eye examination, or do we need to limit who we see?
Yeah, so it's a very good question, because on one hand we are saying open up services, on the other hand we are saying restrict your services. So here, to balance, please choose patients who require a priority examination. So we have dealt with emergencies and we are dealing with other problems. When you say comprehensive, it is comprehensive only when you do a detailed examination. So here I've already warned you, unless it's absolutely necessary at this point of time, don't do applanation, don't do blood pressure monitoring, don't do a dilatation, and do not do refractions unnecessarily. So again, with a little bit of caution for the time being, this probably from our side, from the LAICO side, thanks to LAICO, and I think this is very important aspect that we are talking about, and the best service that we can offer to the people who are in need. So at this point of time, shall I call it version 1 of the LAICO webinar or for Vision Center at this point of time? There are many versions coming from many protocols that are being followed, and guidelines have been changed day to day. Sometimes it's hour to hour also. So at this point of time, don't do a complete examination unless it's absolutely necessary. Like for example, if somebody is coming with a sudden loss of vision, yes, you will have to do a complete examination. But on the contrary, if it's a casual examination, just because they have the free time to come and get it examined, let's keep it for the later times.
There are a couple of questions relating to PPEs. One is about how do we procure these shields?
Yeah.
How do we put or buy these shields? Second question is a full PPE kit required for reception and optometrist? And how do we discard any PPE?
Okay. Very, very valid questions. We've been battling with these questions for quite some time. Now, I must tell you something. I feel villages are the safest at this point of time, because there hasn't been much of a contamination, unlike the cities where people are not following the norms most of the time. Villages, at least you have vast surface lands, so the proximity is not there. But having said that, what PPE to use for what scenario is the big question. Now remember, your protection is for your face, and that protection can be obtained with the 3-ply surgical mask itself. Only if you ensure that there is no space between the mask and the face. So that is not possible with a 3-ply surgical mask, for which you can tape it. You can use an adhesive all around the mask and you can tape it to ensure that there is no space. Number 1 point. Now, your eyes need to be protected, so you can use a goggles, which could be a very simple goggles. And the additional protection that you get is with the face shield. These are all just add-ons. And then in addition, you have a slit lamp guard, the shield there. So in front, when you're standing there in front, you have your gloves, surgical gloves, disposable ones, for your hands, to protect your hands. And then you have the goggles, you have your shield, you also have your mask. I think this is fair enough. And you're not going to wear unnecessary things on your hands. So this will help you protect adequately. And this is what we've been using.
Is it important to use latex gloves mandatorily? Can we use normal disposable gloves because it's so hot nowadays?
Yeah. So there is something called a surgical gloves and a safety gloves. Safety gloves is impossible to wear. So you can wear the surgical gloves, which is disposable, which is not sterile. I understand that somebody has meant the non-sterile latex gloves. It can be worn.
Can they use Perkins tonometer for IOP measurement?
No, please do not use any type of tonometer at this point of time. Perkins is not recommended.
So any contact,
Any contact or any gadget that produces aerosol. So that pressure might produce an aerosol and that will cause contamination. So we are not recommending Perkins at this point of time.
there's something about the wipes a couple of people have asked. One is, do we have an alternative to hydrogen peroxide for cleaning frames? And for slit lamp cleaning, can they use spirit swabs because alcohol wipes are not available?
All right, you don't have to. Oh yes, you can use your alcohol, whichever is available. I mean the spirit, you can always use that. There's no problem. And please use the tissues or the cotton swabs because you need to dispose them. The tendency for us, if when we use a cloth, is to retain it. So just dispose it after that.
So one question from Ms. Rita is, don't you agree that COVID-19 is here to stay? When do you think we will be able to revert to normal with adequate safety measures?
See the question. Now that's a very beautiful question, and that's what we're confronted with every day. Now, I was just telling before we started this webinar, I was just telling our friends here that I'm sure at least 20 to 30% of us are having the antibodies already. We would have probably been exposed to. So I think this is not going to, I mean, this is going to be there. The COVID is going to be there, but we probably will change our strategies and adapt ourselves to suit as and when the pattern changes. See, whenever there is a peak in the number of cases, there is always a scare. So we'll have to learn to live with it and move on. That's why we're starting off, see, on a trial basis, even in the tertiary hospitals, we're not going full swing at this point of time. We are scheduling the patients and we are also ensuring that only certain number of cases are taken for surgeries as well. So we are going at a paced manner so that we are not disregarding whatever guidelines have been quoted. We'll have to ensure that we comply and also ensure that none of us are being compromised, be it patient or the staff.
It's another interesting question about, because a lot of hospitals use the vision center health workers to do door-to-door visits. Can they resume doing that in these days?
See, as long as they carry on with the protective measures, they need to be very well protected. That's all is required. Because if you notice, there are people delivering cylinders to our houses. There are people who are coming to our houses to deliver goods. So with proper precaution, I think you can ask your health workers to go around and do whatever has been done. But you'll have to educate them. See, you'll have to really give an understanding of what the disease is and how it can spread. Because you're not compromising them alone, it's a whole lot of people you'll be compromising. So the education part of it is very, very important. Not to instill fear, but just to let them know that this is how it spreads, so that you have to be careful about what you're venturing into.
Similarly, what about blood sugar testing at vision centers for diabetic patients? Should they continue to do that?
So again, any body fluid is a risk. So it's not necessary at this point of time. It's not mandatory that we do all the blood sugar tests.
And I think this is a relevant question for these times, is what is the role of teleophthalmology in vision center? And it looks like it's going to play a bigger role now.
Absolutely mandatory, because if we have to cut down the visits of patients and if we want to be absolutely sure of the diagnosis, I'm sure all the vision technicians are doing a phenomenally good job, but also to augment from the physician's end, I think teleophthalmology will be the way to go.
And there are several questions, several of them have asked, will there be any guidelines for vision centers from Aravind?
Yeah, we do have the guidelines. We plan to put it up in the website soon. You know, like, see, we don't want to put up something without trying it ourselves. So it's been a week since we started our vision centers. We want to look at the way it goes, and I'm more than happy. I think we'll all be very happy to share, because after all, LAICO's main idea is to share whatever we've experienced. But we don't want to share something without we actually conducting it. So we will certainly do it. probably in a few days from now. LAICO is compiling all the guidelines for all the activities in the base hospital also. So they'll be soon out with it.
So, they were asking about the cleaning that you had mentioned. How long can they wait between patients? Like, for example, if we've cleaned the frames after a patient, can they immediately use it for another patient?
Yeah. So the thing is, you must understand there are only two people in the vision center. So you clean, so you have two boxes or two trays, whatever. It's very simple. You don't have to invest too much now. You just take two trays. One tray will have all the contaminated frames. You just disinfect it, decontaminate it, place it in another tray, and then you go back to examine the next patient and then bring the patient back, the next patient. Patient A would have tried. You're the one who's going to do all the activities. See, between the two technicians, they have to do a lot of activities. So there will be adequate time, and we are scheduling the patient such that we have enough time for the vision center technicians to take care of all these activities. And this has worked out well. And Mr. Gauth has been visiting the vision centers and looking at each of these activities and overseeing that there's no, pitfalls in all of these activities. And that's how we came up with these numbers.
How do they deal with financial sustainability of these vision centers during these difficult times?
So this is a question for the world. I think all of us are going through this phase. We are not, right now, it's more the service mode. I don't think we are looking at the viability at this point of time, because people are wanting service, but they're not getting it. So whatever possible ways we can, probably we should look at it as a CSR activity from the tertiary hospitals. At this point of time, we may not be able to be extremely viable with all the investments that we are making towards protecting our patients, more so are protecting our staff. So I think it will be more as a service to the community at this point of time. And I'm sure with the numbers rising up like this, we'll certainly meet it out at one point of time. Maybe in a few months from now, probably August, September, we should be doing well.
So if, because even at Aravind, we've been seeing patients with some kind of foreign body or trauma. So some related questions are, if any patient with infection or a foreign body comes, do we attend to it? Another Dr. Vijay Tomar has asked, because it's harvesting time, they're getting corneal ulcer patients, so should they proceed to do scraping?
Yeah, so corneal ulcers are something you have to attend to, there's no doubt. If it's a very small one, superficial one, I think through teleconsultations, I think you can manage it, giving some drops. But ideal would be to refer to the base hospital. And they do perform all these scrapings whenever necessary. And all these, again, nothing is compromised. All you need to do is, you'll have to additionally protect yourself. That's all is mandated. It is not about compromising or not doing anything. When it has to be done, it has to be done, but with adequate protection.
Quite a few people have asked about one, that the WHO is asked to use the N95 mask, but we are saying the surgical mask is enough. And Professor Ghulam Mustafa has also asked, can they use the reusable PPEs and how should they decontaminate at the vision center?
Yeah. So what we have done is, see, there's so much of contemplation, contradictions about the N95 masks also. Now, a lot of people are feeling safer with the 3-ply surgical mask because you can just dispose it off after an 8-hour use. The other thing which we have done is we have provided 4 respirators for each of the vision center technician. Now, how we do it is, we ask them to use one respirator and hang it on a door for 72 hours. With this kind of decontamination process, we're able to provide a respirator for every day during the working days, especially from Monday to Saturday. Sundays are closed. So the respirators have been quite helpful in that way. But one word of caution here again, I myself have used the respirators in the OPD and it's very suffocating. But we have to use it to protect ourselves.
One last question. It's about spectacles, you probably may have covered this. Is about because many of the patients come with refractive error. How do we ensure that we get the spectacles to them? Do we deliver the spectacles to their homes?
So again, it's all the question of feasibility. See, in small villages, you can just ask them to just pick it up and go. But in remote places, it's not feasible for us to go and door deliver also. Because who do we have now at this point of time to door deliver? And I don't think at this point of time we have the courier systems which are functioning across the villages and other areas. So I'm not sure how you will pass it on. So the best thing is, as far as possible, you try to give spectacles which are readily available and make it very simple. And if in case you need it, you can ask them to come and pick it up after you make a phone call to them, asking them to just pick it up and there's no crowd. So that's the only way you can decongest your vision center.
There's a few more questions, a lot about handling waste, both biomedical waste and the PPE waste. How do we dispose it at the vision center?
It's a very, very difficult task, especially having all these things with us. Now, we have actually, in whatever we have followed, we have tried to minimize as much as possible. So we are not using anything plastic. All the plastics which we are using are reusable, except I think most of what we are using is reusable. So disposing is not going to be very different from what we were doing earlier. Just the way we were managing the waste earlier is how we would be managing. And remember, we are not seeing a whole lot of patients as well. So that would reduce the bulk.
Two related questions. One is, have we resumed surgeries at the hospital, cataract surgeries, and how can we send cataract surgery patients to the hospital without doing syringing?
All right. So now at the base hospital, we haven't started elective surgeries yet. We probably will resume elective surgeries a week from now, which will probably be the next week. And how do we do so? At this point of time, please remember the reason why we are deferring lacrimal syringing is only because the virus is supposed to be lodged in the nasal cavity. So we don't want to do a syringing. So what is the alternative to syringing is fluorescent dye disappearance test. All we need to do is, this is not going to be a very precise test for to replace the drainage testing of the drainage system, but it is going to give us an idea as to whether there is a block or not. So you just instill a drop of fluorescein stain in the eye, and you can see how it dries up in the eye. And once it is completely, the tear pool is completely gone without any staining, then you know for sure that the drainage is good. So this has to be followed in all the pre-cataract cases or any intraocular surgeries for that matter. They've stopped doing syringing even if it was an emergency. Right now we are operating on phacolytic, phacomorphic, glaucomas, mature cataracts and all those. In that we only do a FDDT. That is a fluorescent dye disappearance test.
So a few of the hospitals, they have the trucking program, that vision centers exclusively for truck drivers. So do they need to take any special precautions for driver patients?
So now if you have these vulnerable groups who are travelers, I think it's best to assume that every patient that you see is a COVID positive patient. Assume that it's a COVID positive patient and take all the necessary precautions and the protective gears that is given to you. And then you should also remember that you should also be very careful about how you return back to your houses. That's very, very important.
Thank you very much, madam. It's been very informative, and I think a lot of questions that we had have been answered.